So this hearing will come to order. I'd like to welcome everyone to the first Joint Economic Committee hearing of the 117th Congress. So welcome back and welcome to all the new members. It's really exciting to see this full force out. And I really look forward to looking with Vice Chairman Heinrich of the Senator, Ranking Member Mike Lee, who chaired this the last Congress, House Senior Republican David Schweikert, and all of our committee members as we examine the many economic challenges and opportunities facing our country. I want to thank each of our distinguished witnesses for sharing their expertise today. Now, my brief opening statement: the end is in sight. The pandemic and its tragic health and economic consequences have dominated our lives for the last year. And after more than a year of physical distancing and mask wearing, of fearing for our health and the health of our loved ones, of widespread and deep unequal economic hardship, the potential for returning to a sense of normalcy is finally within sight. The pandemic will leave no shortage of tragedy in its wake. More than 560,000 people have died in the United States, many isolated in hospital rooms and without their families' last comfort. 31 million that we know of have been infected with the coronavirus, and many of them continue to live with the disease's debilitating symptoms. Communities of color, particularly our Black, Latino, and American Indian communities, have been hit especially hard, experiencing the highest rates of COVID-19 infection, hospitalization, and death. The economic damage persists as well. After job gains of more than 900,000 last month, still close to 10 million workers remain unemployed. 1/4 have been jobless for a year or longer. Another 4 million people have simply left the labor force since the pandemic began. Thankfully, the economy is beginning to recover. Much of that emerging recovery is due to the remarkable vaccination effort unfolding in our country and throughout the world right now, where millions of shots are going into arms every single day. It's an unprecedented undertaking. More than 190 million doses have been administered in the United States. More than 1 in 3 people in the US have received at least one shot. 1 in 5 Americans have been fully vaccinated. At the current rate, we could vaccinate all adults in the United States by the end of the summer. And then perhaps our lives could begin to approach a new normal where we can see loved ones, where we no longer have to choose between going to work and keeping the family safe, where we can enjoy a meal inside a restaurant or a trip to the movies. It is a profound consensus among economists that vaccinations will shape the course of the economic recovery. Forecasts call for economic growth. Goldman Sachs may be the most optimistic, suggesting 8% in 2021. In an interview this past weekend, Fed Chair Jay Powell said, "The economy and job creation are poised for faster growth, and the principal risk is that, quote, we will reopen too quickly, people will too quickly return to their old practices, and we'll see another spike in cases." Although the trajectory of the pandemic recovery is headed in the right direction, it remains precarious and can be derailed by hasty reopenings, new variants, anti-vaccine sentiment, or a lack of access to vaccines. This means that our economic recovery is precarious as well. Public health experts warn that state efforts to roll back mask mandates and physical distancing requirements can backfire, especially in light of highly transmissible and deadlier variants. Michigan's recent experience makes clear that we cannot rely on vaccines alone as our only way out of the pandemic. We've seen recent spikes in cases as the more contagious B.1.1.7 variant has now become the most common strain of the virus in the United States. Younger adults and children are comprising an ever larger share of the new infections. If we cannot bring the pandemic under control both domestically and globally, new variants might become resistant to our current treatments and vaccines, creating a need for adjusted vaccine products, further delaying recovery efforts. CDC Director Rochelle Walensky has said repeatedly that because of these concerns, we cannot let our guard down and must continue to practice mask wearing and physical distancing until we reach herd immunity. There's also profound inequity in access to vaccines. Vaccination rates for people of color, especially Blacks and Latinos, lag far behind the rates for whites. And as a result, pandemic and economic recovery efforts in communities of color may fall behind recovery in white communities. The reality is even worse abroad. While wealthy countries have purchased enough vaccine to cover 2 and sometimes even 3 times their populations, low and middle income countries, which account for 81% of the world's adult population, have collectively purchased only 33% of vaccines. As Treasury Secretary Yellen laid out last week, some low-income countries don't expect to be able to fully vaccinate their populations until 2023 or 2024, which should be unacceptable and dangerous to all of us. To end this pandemic for good, the battle against the coronavirus must be won globally. So while we've made extraordinary progress in the last few months, we're not out of the woods yet. And I really look forward to hearing from our witnesses about the state of our recovery, where it's going, what we can do to ensure things stay on track. So let me now turn this over to Senator Lee for his opening statement. Senator Lee, is you with us? Mike?
Yes. Thanks so much, Mr. Chairman. Thanks for convening today's hearing. You know, after a long COVID winter, one that included some unprecedented strains on our economy and on public health, the spring has brought some welcome signs of life and of hope. Businesses are beginning to reopen, schools are starting to reconvene in person, and friends and family members are finally starting to reunite. Perhaps what's most encouraging and what's helped support the beginning of our return to normal has been the development and distribution of vaccines. But there's still a long way to go. Many Americans still haven't returned to the in-person experiences of the entertainment and travel industries, for example, and our economy is suffering. In order for people to feel safe to returning to in-person interactions that support economic activity, we must continue to improve vaccine distribution. As we consider how best to move forward, it's worth reflecting on our trajectory so far, both the strategies that have helped and those that have hindered our progress. Though vaccine production has had some supply chain setbacks, such as the difficulty in finding vaccine components like reagents and other chemicals that have led to manufacturing bottlenecks, it has overall exceeded expectations. Operation Warp Speed, an initiative begun by the Trump administration, sped the development and the production of several vaccines, including Moderna, Pfizer, and Johnson & Johnson, by purchasing vaccines in development and directing resources towards vaccine manufacturing capacity. In total, through advance purchase agreements and grants, the Trump administration purchased more than 800 million doses through the end of July 2022. The Council of Economic Advisors previously estimated that accelerated vaccine development and distribution by OWS could result in as much as $2.4 trillion in economic benefit if there was a viable vaccine by January 1st, 2021. The effort actually outpaced that timeline, with first doses of the Pfizer vaccine being made available on December 14th, 2020. And the CEA noted that its own estimate might even underestimate the full economic benefit of accelerated vaccine development. In terms of vaccine distribution, there are worthwhile policy proposals to increase the number of people with some protection during that time period in which vaccine supplies are still somewhat scarce. We should be open to creative solutions that can help get people protected more quickly by strengthening the limited supply as far as we possibly can and moving the doses that we have as quickly as possible to as many people as possible. Our main priority should be to extend at least some protection to as many people as we possibly can. States also have an important role to play in distribution. In some cases, we've seen that restrictive federal guidelines and rigid, complex eligibility requirements have impeded states' progress, leading many vaccine doses to being wasted or administered to unintended populations. Lack of health resources at the final stage of local distribution have also presented some problems for many areas. On the other hand, successful states have implemented simple eligibility criteria and used technology to accelerate the distribution. Some have even built systems where patients can register online. Others have used online event hosting software to schedule appointments. And they've also partnered with local businesses and pharmacies. Despite all of the challenges that we've faced, the U.S. has vaccinated more people per capita than most other countries in the world. Nearly 190 million doses have been administered as of April 13th. More American citizens have received a COVID-19 vaccine than tested positive for the virus since the beginning of the pandemic. And nearly a third of the adult US population is now fully vaccinated. There is reason for hope in our economic outlook as well. Expectations are set for a stronger economic response in the second half of the year. The CBO expects real GDP to return to its pre-pandemic level by 2021, and the labor force is expected to return to its pre-pandemic size by 2022. But in order to accelerate our economic recovery, we should look for opportunities to improve vaccine distribution policy. The sooner the U.S. reaches herd immunity through vaccinations, the sooner businesses can reopen to full capacity, and students can return fully to schools, and industries can come back to life, and Americans can return to work and social life without fear. So I look forward to hearing our panelists' contributions today and their insights into how we can do just that. But before I do, I would like to ask Chairman Beyer for permission to submit 5 articles or studies from our witness, Dr. Tabarrok, for the record.
Without objection, Senator, they're admitted.
Thank you.
Senator Lee, thank you very much for your statement. I'd now like to introduce our 4 distinguished witnesses. Dr. Celine Gounder is a clinical assistant professor of medicine and infectious diseases at the NYU School of Medicine and Bellevue Hospital. An infectious disease specialist and epidemiologist, Dr. Gounder served on the Biden-Harris Transition COVID-19 Advisory Board. She's also the CEO of Just Human Productions, which works to build awareness around issues of health disparity. Dr. Gounder is a CNN medical analyst and has written for several national publications. She holds a BA in molecular biology from Princeton University, a Master of Science in Epidemiology from Johns Hopkins Bloomberg School of Public Health, and her MD from the University of Washington. Dr. Paul Romer is the University Professor of Economics at NYU. In 2018, he received the Nobel Prize in Economic Sciences for his work integrating technological innovations into long-run macroeconomic analysis. Dr. Romer is a frequent commentator on the COVID-19 pandemic and has been a strong proponent of large-scale COVID-19 testing as a means of restarting the economy. In fact, about a year ago, Dr. Romer spent an hour with the Joint Economic Committee team talking about how we can use testing to protect the United States. He spent his career at the intersection of economics, innovation, technology, and urbanization, working to speed up human progress. Dr. Romer previously served as the chief economist at the World Bank, and he earned his BS in mathematics from the University of Chicago and a PhD also in economics from the University of Chicago. Dr. Belinda Archibald is an assistant professor of economics at Barnard College, Columbia University. She's done research on the economics of epidemics and vaccinations, and her broader research areas include development economics, political economy, economic history, and environmental economics with an African regional focus. Some of Dr. Archibald's research investigates the role of historical institutions and environment in unequal access to public services and the development of human capital. This research includes the effects of epidemics on gender gaps in human capital investment. She received her BA in economics, philosophy, and a PhD in sustainable development, both from Columbia University. And my mom was a 1948 Barnard graduate. And then finally, Dr. Alexandra Tabarrok holds the Bartley J. Madden Chair in Economics at the Mercatus Center and is a professor of economics at our own George Mason University. Dr. Tabarrok has advocated for policies to speed up the rate of vaccinations, including delaying second doses and fractional dosing. Dr. Tabarrok is a co-author of an FDA review.org, which is a website that scrutinizes the FDA's regulatory and authority and performance. Dr. Tabarrok is a senior fellow and former research director for the Independent Institute. He's a co-founder of the online educational platform Marginal Revolution University and co-author of the textbook Modern Principles of Economics. Dr. Tabarrok is a PhD in economics from George Mason University. So Dr. Gounder, we offer the floor to you for your testimony, and then we'll continue in the order each of you was introduced. Dr. Gounder, the floor is yours.
Thank you. Chairman Beyer, Vice Chair Heinrich, Ranking Member Lee, and members of the committee, thank you for the opportunity to discuss with you today the role of vaccination in our pandemic and economic recovery. It's important to give credit where credit is due. The prior administration helped accelerate vaccine development safely, scientifically, and in record time. The current administration is helping to scale up manufacturing and speed up distribution of vaccines. We are currently vaccinating an average of 3 million people per day. And according to the CDC's latest data, 37% of the total population has received at least one dose of vaccine, and 23% of the total population has been fully vaccinated. Despite recent setbacks involving production and safety concerns with the Johnson & Johnson vaccine, we remain on track to have enough vaccine supply for every adult in the United States by the end of May. Assuming we can continue vaccinating at the same pace of 3 to 3.5 million vaccine doses per day, we could vaccinate all adults well before the end of August. Vaccination rates reflect vaccine supply, access to vaccines, and demand for vaccines. Our supply is solid. We've done a lot of work to improve distribution and access, and yet we still have room to do better. But importantly, we are about to see a big drop in demand, and this is going to have a big impact on our daily rate of vaccination. Supply is already outstripping demand in several states. There's a spectrum of vaccine hesitancy, vaccine confidence, and vaccine seeking. The good news is that the share of Americans who want to, quote, wait and see, what we call the movable middle, shrank from 39% in December to 17% in March. So we made a lot of progress among communities of color and persons for whom issues of access are the greatest barriers to vaccination. The bad news is that 20% of Americans say they will only get vaccinated if required and will definitely not get vaccinated. Our daily COVID vaccination rates could drop significantly within the coming month as a result of dropping demand. With 20% of Americans currently unlikely to get vaccinated and another 25% of the population who are children, we won't be reaching herd immunity for quite some time yet. It's also important to understand that vaccine rollout is necessary but not sufficient for pandemic recovery. And I think of pandemic recovery in 4 phases: ending the emergency, relaxing mitigation measures, getting to herd immunity, and long-term control. To end the emergency, we have to vaccinate the highest risk persons who are most likely to develop severe COVID, most likely to be hospitalized, and most likely to die. That means vaccinating older adults and people with chronic medical conditions, and we must also pay special attention to the hardest hit, most vulnerable communities, including communities of color and frontline essential workers. We cannot end the emergency phase of the pandemic by relying only on vaccination without risking another surge in cases, hospitalizations, and deaths. I think of the pandemic a bit like a speeding car. Lifting mitigation measures too soon is like taking your foot off the brake before putting the car into park. With the emergence of more infectious variants, the virus is hitting the gas at the same time. Vaccination is like a parking brake. It works well once a car is in park, but not nearly as well when you're racing down a highway. We are likely facing a prolonged interim period when we can safely lift mitigation measures because the most at risk have been shielded by vaccination, but before we've reached herd immunity. And this means that even once restrictions are lifted, we're unlikely to get back to business as usual right away. While COVID credentials may not be mandated by the government, the private sector is forging ahead. The purpose of COVID credentials, what some mislabel COVID passports, is to demonstrate that when individuals engage in certain activities, they pose minimal infectious risk to others. COVID credentials may take the form of a COVID test result as well as COVID vaccination status. And COVID credentials are not COVID vaccination mandates. Finally, our pandemic recovery plans must address chronic underfunding of the CDC and state and local health departments and build a strong, modern public health infrastructure. We need a professional public health core and 21st century bioinformatics and laboratory systems. Our financial and political investment in preparedness for epidemics and pandemics should reflect the serious health, economic, and national security triple threat they pose. We must re-engage on the global health stage as this pandemic has shown us, the emergence of a new virus halfway around the world poses a very real and present danger to us all.
Dr. Gander, thank you very much. And I recognize Dr. Romer for his testimony.
Yes, Chairman, Vice Chairman, Ranking Member, other members, thank you for the chance to speak with you today. As all of the speakers have emphasized so far, we're benefiting from some dramatic successes right now. The success in developing the vaccines, and then the very difficult logistical challenge, but it's one we've successfully met, of getting these vaccines into the arms of the American people. Now, in the context of these two dramatic successes, I want to offer two notes of caution. The first is to remind everyone that the damage to the economy and to livelihoods has been very significant, and we need to have an economic recovery that gets everyone who was working before in 2019 back into some kind of employment opportunity, and only decide that we've recovered when we reach that point. But yet we should go even farther. We shouldn't just get back to the employment to population ratio we had in 2019. We should aim for the employment to population ratio that we had in 1999, 20 years ago, which was 1 percentage point higher. We've tolerated over the last 20 years a steady reduction in the employment to population ratio, which has not been visible in our unemployment rate, because the employment to population ratio falls when people become so discouraged they stop even trying to find a job. So we need a goal for recovery, which is not just to get back to the kind of low unemployment rates we saw in 2019. We want to get back to the very hot labor market conditions of 1999, where more people could work and where wages for the lowest skilled members of the workforce were rising because of the demand for these workers. So we can't lose track of the right measure of recovery, and we can't give up on recovery until we get back to full recovery. The second cautionary note is that we run, even though the vaccines can with certainty end this pandemic by the fall, we run a non-trivial risk of, we face a non-trivial risk of a third wave of infections and deaths in the spring and summer. This is because we've got a race right now between a new variant, which is spreading rapidly, which is much more aggressive. So control measures that worked for the old variant will not work for the new variant. So we've got a new variant which is spreading rapidly, and then the opposing advantage we're getting is we're vaccinating more and more people. There's a race between those two effects, and it's complicated because there's also a tendency for people to see deaths are going down, at least for now. Vaccinations are going forward, so social distance measures are being withdrawn. And this means that at least temporarily during the spring and summer, the relaxed social distancing measures and the more aggressive variant could lead to one more wave of infections and deaths. What we're seeing in Michigan is a kind of an early warning signal of what we could see throughout the economy. If this happens, we need to not panic. We need to understand we'll get to the end of this by the fall. We need to not be too obsessed. We don't need to obsess about who to blame, who's at fault. We do need to think about what we can do. And Dr. Gunder, if you read her recent op-ed, makes this very important point that accelerating vaccinations, which would be good across the country, is not the right spot treatment effect when we do see this new wave emerge. We need things that act more quickly. And the kind of thing that could act quickly is to get tests into the hands of people who might be infected. And if they can test and find out quickly that they're infected, they will tend to isolate themselves. They will try to protect the people around them. So my advice on Michigan is the kind of advice I gave a year ago for the country, which is make these tests available. I'd be carpet bombing Michigan right now with these at-home tests that people could take. Don't worry about whether they get recorded in the data. Just don't worry about anything, but let people take these tests, find out if they're infected, and isolate themselves right away. And they can go get a confirming test from some official source. But this is the kind of the measure that could help us during the spring and summer. And of course, social distance will save lives during this period, but we've got to be realistic that it's going to be hard to keep people sticking to these social distance measures when they're seeing, at least for a time, so many signals that look optimistic. So to conclude, if we work hard enough, we can recover not just to where we were in 2019 or 2009, but 2007, but all the way back to 1999. That's the kind of recovery we should aim for. And we'll get through what could be a little bit of a troubling period in the next few months. Thank you.
Great. Thank you, Dr. River, very much. Dr. Archibald, the floor is yours.
All right. Thank you very much, Chairman Beyer, Vice Chairman Heinrich, and Ranking Member Lee, and committee members for the opportunity to testify today. So I just wanted to highlight 3 key points around this theme that any effective economic policy needs to focus on equitable recovery. So first, highlighting the differential risks and disparities in economic recovery that has been faced by Black communities during the pandemic. Second, assessing the role of vaccination in economic recovery, especially addressing these disparities that my colleagues have mentioned in access and also in vaccine compliance. And third, highlighting 4 main policies for more equitable post-pandemic recovery. So on this first point, so we knew early on that Black communities and Black populations were disproportionately being infected, and also the case fatality rates were higher among Black communities at the start of the pandemic. Part of the reason for this was that Black workers were more highly represented relative to their population shares in the kind of essential service sector. And why is this? This is due to the history of racial discrimination in labor markets in the United States. So that said, despite the fact that Black communities have been disproportionately negatively affected during the pandemic, we've seen that the kind of pandemic response and the economic recovery has been unequal and uneven. So we've all seen the unemployment statistics that came out last month. So 6% unemployment rates were kind of improved from last year. But if you look at the unemployment rates by race, you will notice that the Black unemployment rates is still twice the rate of white workers. It is still around 9.6% compared to 5.4% for white workers. We also know that Black business owners faced much higher employment losses at the start of the pandemic. Lost about 41% of employment between February and April of last year, compared to a 17% loss in employment for white business owners. Now, despite these losses, Black business owners, especially Black women business owners, were less likely to receive loans from the Paycheck Protection Program due to poor targeting and also partly due to lending discrimination. Second point on vaccination, we know that vaccination is a key part of the economic recovery, but as has been mentioned earlier, there are disparities in access to vaccines. We need to target this 85% vaccination rate, according to public health experts, to get the positive external benefits of reduced diseases, cases of disease from the pandemic. We're currently at 22% fully vaccinated, but if you look at, again, the kind of Black-white difference in vaccination rates, the vaccination rate among white populations is around 28%. So it's about 2 times higher than vaccination rates for Black and Hispanic populations, which are around 17 and 16% currently. So we definitely need more equitable distribution that focuses on improving access in Black and Hispanic neighborhoods, especially given that, again, these populations are relatively overrepresented in these essential service workers that we know is a key sector, a necessary sector for the economic recovery. So lastly, just on these 4 policies for a more equitable post-pandemic recovery. So 1, definitely we need much better targeting of grants of credit to Black neighborhoods, to industries where you have higher concentrations of Black business owners. More regulation and monitoring is also needed to reduce lending discrimination. Second, we need to address the disparities in vaccine access. We all know the people who study the kind of history of vaccine compliance. We know that the kind of history of racism in medicine in the United States has led to the mistrust that we are seeing among Black populations today when it comes to the vaccination. So really working with trusted community partners to disseminate in Black neighborhoods to disseminate information about vaccines and improve access through local clinics in Black neighborhoods is essential, again, to close these disparities in vaccination and get us to this 85% coverage. Thirdly, we know that the pandemic has widened racial and gender disparities in employment, in health and wealth. These effects will last for a long time, except we have real concerted policies, everything around, kind of thinking about universal health care, thinking about government-funded savings account for low-income families, thinking about, support for and protection for labor in these essential service sectors as well. And then lastly, thinking forward, right? We expect that we might see more of these pandemics in the future. This is what our environmental health colleagues are predicting. So we really need to strengthen environmental regulation around, for example, clean air quality to reduce the health and environmental vulnerabilities faced by Black populations from these pandemics. So to conclude, any effective pandemic economic recovery needs to focus on equitable recovery. It needs to be aimed especially at improving the lives of Black communities of color, and women within these communities that have been disproportionately harmed by the pandemic. Thank you.
Dr. Archibald, thank you very much. And finally, we'll hear from Dr. Tabarrok. Dr. Tabarrok, the floor is yours.
Thank you, Chairman, Vice Chairman. It's an honor to be here. About a year ago, Nobel Prize winner Michael Kremer and I were asked by the Domestic Policy Council of the White House to write a report on using incentives to accelerate vaccines. Joined by a number of other top economists, we wrote a report advocating spending on the world scale of approximately 150 billion to invest in 18 vaccine candidates. We wrote similar reports for the British government and also came to later advise the World Bank and other organizations around the world. The world did not go as big as we wanted. Operation Warp Speed, however, was by far the best. These spent about $15 billion and were tremendously successful. In a recent paper in Science, we calculate that if we get 3 billion courses of vaccine this year, which is a conservative estimate, that will be worth $17.4 trillion to the world economy. And Operation Warp Speed should be credited with a significant fraction, certainly not all, but with a significant fraction of that success. Moreover, it is not too late to do more. We calculate that if we could get an additional 1 billion courses of capacity online this year, that would be worth 500 billion to 1 trillion for the world economy, depending upon how quickly it can be brought online. Now, is it possible to get more doses this year? Yes, it is. The Biden administration spent 269 million, giving that to Merck to increase the capacity to produce the Johnson & Johnson vaccine. That was a smart investment and continues to be a smart investment. Another smart investment which we could make is to invest in nasal vaccines. The next big hurdle is going to be vaccine hesitancy. And a significant fraction of vaccine hesitancy is fear of needles. Adults don't like to say that they're afraid of needles or that they don't want to get a shot because of needle fear, but that is in fact the case. A nasal vaccine would have advantages not only in reducing vaccine hesitancy, but nasal vaccines stimulate the mucosal immune system, which is where the virus attacks. So they also have medical benefits as well. Moreover, nasal vaccines or oral vaccines are going to be important to vaccinate children. And that also is going to help us to get to herd immunity. After we vaccinate the United States, our next big job is to vaccinate the world. And there are health, economic, and political reasons to do so. The unvaccinated are the biggest risk that we face for generating new variants and mutations. You've heard no doubt about the South African and Brazilian variants. Well, the best way to protect your constituents from South African and Brazilian variants and others is to vaccinate South Africans and Brazilians. Moreover, economics. Even after the United States and other high-income countries are vaccinated, the United States is still going to face economic costs from reduced exports, reduced imports, and supply chain disruptions due to COVID elsewhere in the world. So there are sound economic reasons for vaccinating the world. And an additional $4 billion donation to COVAX would go a very long way to getting that last mile, getting those last people vaccinated. Finally, political reasons. We can have an American plan to vaccinate the world or a Chinese plan. I would prefer that we have an American plan. Next, as we vaccinate the world, we need to think about dose stretching. We know from the clinical trials that both the Moderna and Pfizer vaccine, the first dose is about 80% effective. And in my view, it is better to bring more people from 0% to 80% protected than to bring one person from 0% to 80% and then boost them to 95%. Speaking loosely, the first dose protects you from being killed, from dying. The second dose protects you from getting the sniffles. Related to this, we should investigate fractional dosing. The phase 1 and phase 2 clinical trials indicate that half dosing would be also potentially very, very effective. And if one thinks about this, half dosing, that would be equivalent to doubling the number of Pfizer and Moderna factories. So that would be extremely valuable if we could do that. Great Britain and Canada have moved to delaying the second dose, and other countries will soon follow suit. So summing up, it is not too late to do more. We should invest in nasal vaccines. We should vaccinate the world. We should stretch doses through fractional dosing and delaying the second dose. And this is going to be important to vaccinate the world quickly. Thank you very much.
Thank you, Dr. Domrick, very much. We'll now begin the first round of questions, and I will lead. So, Dr. Gounder, let me start with, in your testimony, you wrote that most scientists believe that SARS-CoV-2 is here to stay, that this virus is going to become endemic and will be around with us for years and years to come. What are the implications of that understanding?
So first of all, the reason that this is not a virus that we can eradicate is because it does infect other species. There are very few viruses that can be eradicated. Smallpox is one of the few, which we have successfully eradicated, and we're hopefully going to be eradicating polio in the coming years. But I think the fact that we've been working at this with polio also speaks to the fact that this is a very difficult thing to do, even when it is not a virus that infects other species. So we do realize that there are going to be pockets of people, whether it's in the United States or overseas, who will choose not to be vaccinated, who can't be vaccinated, who don't have access. And then others who may be vaccinated, but who have, for whatever reason, either waning immunity or just don't mount an immune response. And so we are going to see ongoing transmission. And so that means we can't only rely on vaccination. We need to anticipate the needs for whether it's testing to make sure that we can assess if somebody's infected, so we can triage and isolate as appropriate. We also need much better therapeutics for COVID. Right now, really the best therapeutic we have is dexamethasone, which is an old steroid. We have monoclonal antibodies, which have a lot of trade-offs in terms of risk, especially as you have the rise of these mutant variants. And then we have a number of old drugs that we're trying to repurpose and study for their use in COVID, but we really don't have a slam dunk here. And so that's one area we really do need to be looking at. I think you're also looking at a lot of people who will be COVID survivors. And how do you even accurately assess who was a COVID survivor, and then be prepared to manage all of the health and disability rehabilitation needs that those people are going to have? So I think we need to be anticipating and preparing on all those fronts as well.
Thank you very much. Dr. Romer, when we spoke a year ago, you were thinking then about testing the entire population every 2 weeks. I'd love to know why the fast tests haven't hit the way we had hoped. And also, the 1% higher employment to population ratio of 22 years ago. What should we be doing right now from an economic policy standpoint to move it back?
Yeah.
What are the hurdles like childcare affordability?
Yeah. So I think it's an interesting question why we didn't make the same kind of push on testing as we made on vaccines. And I think there are at least two possible contributing factors. I think one is that the healthcare community has been hesitant about testing when there's low prevalence of a condition. And in clinical care, it doesn't make sense to just test people with no other indication that they're sick. But screening is a very different use of testing. And I think people have been a little bit slow to appreciate the potential power of screening. The other factor, I think, which you cannot deny, is that we had an administration that had a very explicit policy of trying to reduce the number of tests because it didn't want more tested confirmed cases as a sign of the seriousness of the pandemic. So I think both bad administration policy and hesitancy contributed to the failure to use the tests. But just as Dr. Tabarek said, it's not too late here. We have a really serious question we need to address about how do we help places like Michigan that are getting hit so hard. And I think these new at-home tests that are like little cards, we should be giving those out to everybody in Michigan, getting everybody who is willing to do one of these tests, and just understand that they will isolate themselves if they get a test that signals that a test result signals they're positive. Now, on how we get back to the kind of labor market conditions of the 1990s, I think the most important thing is we agree on that's the goal, and we agree on this metric of the fraction of adults who are employed. Once we agree on that, then we kind of take the stance of try many different things. Stimulus like we're doing right now, aggressive stimulus will be part of this. An infrastructure bill could be part of this. But there could be other things we could do. We could look at things like targeted subsidies for employment or for new jobs or for hiring. There's many things that we could do, but we've got to get away from unemployment rates as our metric of success and get to the more important measure of employment rates. And we should remember that by that measure, the employment rate, the United States now lags far behind other nations that it used to do better than: Canada, Great Britain, Germany, Sweden, Australia. So we really have kind of failed repeatedly to recover and achieve the kind of employment and the widespread benefits from work. And we really need as a nation to commit to doing whatever it takes to get to get back to that point.
Thank you, Dr. Ruber, very much. I recognize Senator Lee for his questions.
Thanks so much, Mr. Chairman. Dr. Tabarek, let's talk about the $1.9 trillion American Rescue Plan for a moment. This $1.9 trillion bill was a massive economic stimulus, and it was sold as a COVID relief package, even though less than 7% of it was actually allocated to COVID testing and vaccines. So, Dr. Tabarek, given that massive economic spending today imposes consequences on future generations, does it make sense to focus spending on activities necessary for recovery, specifically those that help us reduce the incidence of COVID?
So I think there's no recovery until COVID is defeated. We're close to that. We should have spent more on vaccines. I think that's clearer today. We should still be spending, as I suggested, on nasal vaccines and oral vaccines. I agree entirely with Dr. Romer that testing was underdeveloped and could still be used today. Denmark is testing 8% of their population every single day, about 50% a week. So Denmark is getting close to what Paul Romer originally argued for a year ago. And rapid tests, I think, would be very useful in Michigan, as Dr. Romer said. The rest of the stimulus budget, I think, just has to be evaluated on its own ground. Not as stimulus, not as COVID fighting. You just simply have to ask, do we want this particular investment? Does it face a cost-benefit test? What we spend on vaccines and testing has a tremendous multiplier effect. Everything else is much, much smaller, much, much smaller. So I think those other investments need to be evaluated on their own grounds.
Yeah, that makes sense, and I tend to agree. And we've got to, in looking at that, we've got to remember that one of the strengths of our system of government, which is rooted in federalism, um, it's a system in which sovereignty and decision-making authority are shared. They're divided between federal and state governments. But during the COVID-19 pandemic, states were often dependent on the federal government for both financial assistance and guidance. So I've got a couple of questions related to that. In what ways do you think states' reliance on federal support might have inhibited an effective, innovative pandemic response? And what lessons can we learn from state-level experimentation where it did occur? And does this show us how we can support a decentralized type of innovation for future crises?
I was disappointed by the reactions of many states and local governments. Let me give you a few examples. The states and local governments were told months and months in advance, the vaccines are coming, the vaccines are coming, the vaccines are coming. And yet when the vaccines arrived on the doorstep, they said, well, we don't have enough money. We don't have enough money to set up clinics, which is total nonsense. The states and the local governments have truly spent trillions of dollars. You're telling me they could not find a way of reducing their budgets, when this huge, incredible benefit of getting the vaccination clinics was available? No, so that was a very poor response, and it slowed us down in the early weeks. I do think that a lot of energy has been drained to the federal, to the presidential system, to the executive. I would have liked for there to be more experimentation at the state level. As far as I know, for example, a state could have could have required going with first doses first, delaying the second dose. No state did that. But so I would have liked to have seen more experimentation and a more federalist system. It is one of the United States' great strengths, and I think we're losing it by focusing too much on what's going on with the federal government.
Yeah, no, I very much agree. I'm also concerned about the fact that with the recent virus mutations that we've seen arising in Spain, the UK, South Africa, and Brazil, we've got mutations that could threaten the efficacy of our domestic vaccination process as these new strains appear in the United States. Can you talk to us a little bit about the importance of administering more first doses, especially in light of this? And can you describe some of the economic and societal trade-offs of not pursuing the first doses first policy?
Right. So the first dose appears to have protected about 80%. That's very good for the individual. Okay. But in addition, when you protect two people at 80%, rather than one person at 95%, you reduce the transmission rate of the virus. To reduce the transmission, it's much better to protect more people. It also looks like protecting more people, vaccinating more people, which you can do by delaying the second dose. It looks like that will also reduce mutations. So we don't know that for sure, but that's what the epidemiologists are now thinking. So by protecting more people, we reduce transmission, we reduce mutations, we get more people vaccinated sooner. And then finally, I'd just like to reiterate that another way, in addition to this, we need to do this for the entire world, because the best way to protect against South African, Brazilian variants is to protect South Africans and Brazilians. And so we have a economic, medical, as well as a political and ethical responsibility to vaccinate the entire world. And the United States is only one of the very few countries which can credibly do this. And this is a good opportunity to show our entrepreneurship and our power in the world and our benefit to the world.
Senator Lee, if I could, I'd like to reinforce a point that you were pointing to, and it's a discussion we need to have. If you think back to the 19th century, the way the United States built the best university system in the world was not by saying we're going to have this national university, which is this shining light for the world. We said we're going to have universities in every one of the 50 states. And so the Morrill Act, which created the land-grant universities, built this very robust system. Now, fast forward to the most recent period. When we think about the capacity of the CDC or the FDA, We've done the opposite. We've said, let's build this enormous capacity that's centralized under the control of the federal government and make all of the states dependent on those organizations. And they have sometimes erred, and they've left us with what the engineers call a single point of failure. I think we need to think hard about investing more in public health and regulation, but perhaps going back to the methods of the land grant approach and invest in that capacity in the states rather than creating these federal single points of failure.
That's fantastic. I'm pleased to hear about your enthusiasm for federalism. Let's bring back the Morrill Act.
Thank all of you very much. So let me now recognize the senior senator from New Mexico, Senator Heinrich.
Thank you, Chairman. And I want to start with Dr. Gounder on an issue that's been, very much in the news in just the last couple of days. Yesterday alone, COVID claimed 987 lives in the United States, 9 of those in my home state of New Mexico, that I'm proud to say is at the forefront of trying to develop herd immunity. Meanwhile, out of over 6.8 million doses received of the Johnson & Johnson vaccine nationwide, 6 people have developed a rare and serious form of blood clots. So from what the CDC and the FDA and Johnson & Johnson have stated publicly, those 6 individuals also had a known and defined risk profile with respect to blood clots. So how can we properly weigh the relative risk of COVID versus the Johnson & Johnson COVID vaccine to ensure that we are saving as many lives as possible?
Thank you for that question. I think it's really important to understand that the FDA has not pulled the Johnson & Johnson vaccine from the market, that the emergency use authorization still stands. This is just a pause, a timeout for the scientists to step back and review the data. And I think that's really important because when you look at what our biggest obstacles are in the coming months, it is really around vaccine demand or hesitancy or confidence, whichever word you want to use. And one of the biggest drivers, especially in those who are most recalcitrant, most resistant to getting vaccinated, it really comes down to either a lack of trust in health systems or a lack of trust in the government. And so it is absolutely essential that the CDC and the FDA behave in a way that is transparent, honest, above board, where they show they're doing their due diligence, because that is really what's going to predict in the longer term whether people feel comfortable getting vaccinated. They need to trust in the government, in the CDC, in the FDA. And by doing this review that's going on, actually, I think as we speak today, I think that is what is going to get us there. We have seen, as you mentioned, 6 of these severe side effects. They are all in women who are between the ages of 18 and 48, may have had other predisposing conditions. And I think there's quite a good possibility that what you'll see happen, and we've seen something similar happen with the AstraZeneca vaccine in Europe, is that the CDC and FDA will recommend potentially restricting access or restricting use of this vaccine for certain populations. We have not seen any of these severe side effects here with J&J among men, for example. We have not seen that side effect with older people. And so it may just be that they step back and say, maybe this is not the best option for younger women of reproductive age, but for the rest of the population, this continues to be a great option. I think as physicians, we err on the side of doing no harm. And so I think it's really important that we abide by that. And I think it's really important that this message got out there as soon as possible so that doctors and patients know what to look for. The most common treatment we use for blood clots, heparin, is actually dangerous for this particular kind of blood clot and can be deadly. So it was really essential to get the message out there as soon as possible so that if me, for example, as a provider, I have had patients who got the J&J vaccine. If I see one of those patients back, I know what to be looking for and what to do.
Thank you, Dr. Gounder. What you outlined there in terms of changing the target population is exactly what I was discussing with the White House just minutes ago. And so I'm hopeful that we can be absolutely transparent in this process, look at the data, and then hopefully get this very efficacious vaccine back into the places where it's appropriate, because it is our best tool in some of the hardest to reach communities. Fractional dosing, is that something, Dr. Gounder, that you would agree with Dr. Tabarrok on? And should we be looking at vaccinating the entire country with the first dose, for example, and then coming back and prioritizing second doses for the most immune compromised, and having that same sort of phased approach that we've used in New Mexico to really get ahead of most of the rest of the country in terms of developing herd immunity?
I think you need to be very careful in how you interpret the data about 80% effectiveness after first dose and over 90% after second dose. I think the problem is immunity is not on or off. It is a range, a spectrum. And so you may be immune after one dose to the most prevalent original strains, but now we've also seen the rise of the B117 variant. And also, as you mentioned earlier, as we mentioned earlier, the variants out of South Africa and Brazil. And we have several studies now that indicate that after one dose, you still have breakthrough infections with both the B1351 from South Africa and the B117 from the UK. So there is a very real risk that you would be creating this prolonged window where you would be selecting for creating immune pressure for more of that to emerge. That said, I think the fractional dosing strategy is something that should be studied, can be done pretty quickly still, and is something that we should go ahead and evaluate. And if that proves to be as effective in terms of the immune response elicited as the current full dose, that's something we should absolutely be doing.
Great. Thank you very much. Thank you, Chairman.
Yeah, thank you, Senator, very much. And I recognize my fellow Ways and Means classmate, the gentleman from Wichita, Mr. Estes.
Well, thank you, Chairman Beyer. From the beginning of the health crisis, we were told that vaccines and herd immunity were the keys to reopening the economy. Now that we have multiple vaccines and two more in phase 3 trials, we're moving forward with that. And having 180 million people, Americans that have already received at least one dose of the vaccine, and a vaccination rate of 78% of those over 65. What I hear in my district in Kansas is that, when can we get back to life? A lot of businesses have suffered, children falling behind in school, and a lot of people have lost their jobs. We have done a mixed review or mixed results maybe in terms of vaccinations within the state. Specifically, we've done a good job vaccinating seniors and now vaccinating, reaching out to all adults, but we've ranked 35 in the country out of swiftly administering the vaccinations that have been given to us. The Operation Warp Speed, as mentioned earlier, and some smart investments. The United States were able to develop this vaccine in a record time, and the Trump administration purchased over 800 million doses, which has set things up now and at the end of the Trump administration and with the current administration for success. Although experts repeatedly said we wouldn't have a vaccine by the end of 2020, they were wrong. Tomorrow, 26 states will expand vaccine eligibility to all adults, and by May 1st, all states will have open eligibility. But instead of focusing on COVID relief to help get the economy going, some of the discussions and some of the bills, like the rescue plan, has very little funding for vaccine distribution efforts, and instead spends a lot of money bailing out states, again, taking away from that federalism mindset. Even PolitiFact, which is not known for a conservative point of view, has admitted that the COVID-19, the American Rescue Plan isn't a COVID-19 package. And I quote that at the end, direct COVID-19 spending spends about 8.5% of the bill's $1.9 trillion cost. Instead of backing big government spending initiatives, we should focus on crushing the virus, kickstarting the economy, and getting Americans back to work. By implementing pro-growth policies to help American businesses, such as R&D expensing, which is going to be expired in this year. We need to make it permanent in order to make some of the jobs back in America. I do want to ask a couple of questions of Dr. Tabarrok. Although through Operation Warp Speed, the vaccine testing and production was able to be conducted in tandem and in a more streamlined manner. How can we formalize or codify this process to help make sure that we minimize some severe economic impacts in the future?
Yeah, so I think one of the silver linings to the crisis is that it's shown that FDA delay can also be very, very costly, right? So people are seeing for the first time that the longer the FDA takes to approve, whether it's a vaccine or a drug or something like that, can have a real consequence in terms of people dying of COVID or some other disease. This is also true for cancer. This is also true for heart disease. This is true for all of the products that go through the FDA. It now costs over $1 billion to get the typical new drug approved, and we need to find some way of reducing that to have more experimentation and more new drugs, because new drugs absolutely do save lives. So if we can find a way of using our experience from COVID to accelerate FDA approvals across the range, I think that would be tremendously beneficial to American patients.
Well, that's great. That kind of leads into another thought I had around, the breakthrough that we had with mRNA technology really did allow us to develop the vaccine very quickly. Are there things that we can do, incentives, such as improving R&D expensing or genius prizes, some of those so-called genius prizes that would help us make breakthroughs in the future?
Yeah, so 2 points. Going back to one of the earlier questions which was asked is, what about if COVID becomes endemic? Well, one consequence of that is that every investment we make now is going to have a very long payoff. So that's great. So this increases our incentive to invest in mRNA technology, which is capable of not just producing vaccines, but is also capable of producing drugs to treat cancer and heart disease and so forth. So I think all of these things are a great way to invest. R&D expensing may be certainly a part of that. And prizes. Yeah, I do think that prizes should be looked at more. The pre-market purchases, the advanced market commitments which we made for Pfizer, promising we're going to buy hundreds of millions of these doses, that's very similar to a prize. And that worked very well at incentivizing Pfizer to invest billions of dollars in factories, which is now paying off now.
Yeah, thank you very much. And Mr. Chairman, I yield back.
Yeah, thank you. Thank you, Mr. Estes. I now recognize whom I believe is the senior senator from Georgia, Senator Warnock.
Well, thank you so very much, Chairman Beyer, for that promotion. Senator Ossoff, who is my colleague and friend, will be glad to know that I'm now the senior senator. He's actually the senior senator. Let me note it's only because O comes before W. I tell you, I've been suffering my whole life having my last name Warnock. It's the only reason. He's the senior senator because he's Ossoff and I'm Warnock.
There's no fairness. You got more votes than he did.
Go figure. Well, I didn't say all of that. You said those things, but we both won. Listen, thank you so much. It's an honor to be here at my first Joint Economic Committee hearing, and I look forward to working under your leadership and working with all of my colleagues to discuss issues and propose solutions that will allow for a robust economic recovery. As has already been discussed in this committee hearing, the COVID-19 pandemic has, while it has impacted all of us, some communities have experienced a profound, disproportionate impact. And I'm speaking in this instance about women in general, particularly low-income women and women of color, who are not only experiencing the steepest job declines, but also severely lagging in the overall jobs recovery. It took until 2018 for the rate of employment among Black women to recover from the last financial crisis, almost a full decade later. And now almost all of those hard-won gains have been erased due to this economic downturn created by a once-in-a-century pandemic. And so I'd like to ask Dr. Archibald, based on your experience studying how pandemics affect economies, what should we expect about our own economic recovery if past is prologue? Should we expect the economic prospects for women, and especially women of color, to continue to lag behind? And what can we do to avoid that from happening?
Thank you very much, Senator Warnock, Reverend Warnock. I don't know if you remember, we met some time ago, but nice to see you again. And it's a very important question. Nice to see you again. Very, very important question. It's something that I've been studying when I study the epidemics of, or the effects of epidemics on gender inequality. We're seeing that women, generally disproportionately are involved in home production, right? So a lot of women dropped out of the labor force to take care of family, to take care of children. And one of the things that, the official statistics might disguise on kind of the labor force participation statistics, the unemployment statistics by gender, is that we might be missing a lot of women who have just dropped out of the workforce altogether, that are no longer looking for jobs, right? Which would not be reflected in the unemployment statistics. So this is incredibly worrying. This is something that, in other contexts that I've looked at, we see that, these widened gender gaps in human capital investment, in the labor market, in educational attainment. These things can persist for a number of years, except we have, again, policy that is not just a kind of blanket policy about epidemics, a policy that says we are going to take very seriously the fact that certain populations, as you said, Senator Warnock, are disproportionately being harmed. Like women are disproportionately being harmed by the pandemic. They are dropping out of the labor market almost entirely. How do we get them back to pre-pandemic levels, and even, I would say, better than pre-pandemic levels, especially if we're looking at women of color, Black women who were in pre-pandemic times much worse straits when it comes to unemployment rates. So what does this mean? This means like thinking about, when we think about stimulus and cash grants, thinking about incentives that are targeted by gender, thinking about incentives that are targeted towards households where women are living in and are doing a lot of unpaid care work and labor, and really being very deliberate about the kind of policy, kind of targeted policy, and thinking about the kind of gender and racial implications of the policies that we're passing. So I think that's important. And I just wanted to add, just to respond to, I know this is like, I've been listening, very interesting conversations and responding to Dr. Romer's point earlier. I think this is actually where you really need centralized authorities. So the CDC is important. The WHO, in my experience, is very important in terms of coordinating these efforts, and also coordinating efforts that, again, think very carefully about the gendered and racial disparities that come about from the effects of the epidemics. So thank you very much for the question, Senator.
Thank you so much. And I've got a few seconds. So we passed the American Rescue Plan, which is, a step in addressing some of the disparities that you talked about, exacerbated by the pandemic. We're now focused on infrastructure, the American Jobs Plan. And if you think about women and child care and a whole range of issues, what kinds of things should we be thinking about as we put together an infrastructure program that takes seriously the need to address these disparities as we think about jobs and the economy?
Right. So one thing that my colleagues have studied and mentioned is thinking about subsidies for childcare. So that's something that, again, women are disproportionately dropping out of the labor market to take care of children, a lot of women to take care of household members that were sick. And so thinking about these like subsidies for childcare, thinking about, whether it's kind of easily low cost, easily accessible work in kind of retraining programs to get women back into the workforce. These are the type of policies that I think would be very effective and have worked in other contexts in closing these gender gaps as a result of epidemics.
Thank you so very much.
Thank you, Senator, very much. I now recognize the senator from Texas, Senator Cruz.
Well, thank you very much, Mr. Chairman, and welcome to each of the witnesses. Thank you for your testimony. Dr. Tabarrok, I want to start with you and address a topic that is of significant concern to me, and that is the topic of vaccine passports, where there's been a lot of discussion about requiring vaccine passports, either the federal government requiring vaccine passports or individual private companies requiring vaccine passports to be able to utilize transportation, to be able to utilize essential infrastructure. I have deep concerns about any mandated vaccine passports. My concerns include concerns about protecting patient privacy rights, what personally identifiable information would be shared, who maintains the information, whether patients have provided informed consent on the use of this information, can the information be shared or exploited by governments or businesses, what are the risks of hacking this information by foreign nations and criminals, and also the significant potential for discrimination against individuals who either make the choice not to get the vaccine or for various medical reasons are not suitable candidates to receive the vaccine, whether they will face discrimination in terms of public carriers, discriminations in terms of being able to stay at a hotel, discrimination in terms of being able to eat at a restaurant. And in my experience, I think a lot of Americans, certainly a lot of Texans, are very concerned about this. Recently, White House Press Secretary Jen Psaki said, quote, "There will be no federal vaccinations database and no federal mandate requiring everyone to obtain a single vaccination credential. America's privacy and rights should be protected so that these systems are not used against people unfairly." I was encouraged by those comments. I'm not sure I believe that's where the administration will end up, but I liked at least that they were saying that. I think that was a step in the right direction. Dr. Tabarrok, do you agree that the federal government should not establish a federal vaccine mandate?
Yes, I agree with that. I do have mixed feelings on so-called vaccine passports. I'm not particularly against universities, for example, requiring their students to be vaccinated, as a number of universities already have suggested they will. So I think private employers should be allowed to say that we want our employees to be vaccinated. I do think the following is maybe some way of finding some compromise, and that is, look, this is going to be a very temporary problem. I believe that we will quickly, with more vaccinations, we will quickly get back to normality, even as early as the summer, the late summer. I think these issues will begin to fade away at that time, particularly as most people will be vaccinated just because it's a smart thing to do. It's the rational thing to do. And as death rates fall, as the infections fall, I think some of these calls will go away. Many countries, however, will require a vaccination to get into the country. So literally, you will require to be vaccinated if you want to visit a lot of foreign countries. I myself am eager to travel again, and many countries already require a yellow fever vaccination. And so I think that's going to become fairly common, whether one wants it or not. I am against a federal mandate, but as I said, I think if we can make vaccines easy to get, okay, low cost, then people are going to be vaccinated, and this problem will fade away quite quickly.
Well, look, I agree that vaccines should be widely available. I've been vaccinated. My wife has been vaccinated. Both my parents have been vaccinated. That being said, our children who are 10 and 13 have not been vaccinated. And in terms of the cost-benefit analysis, I think it's quite different for an adult or for a senior than it is for a young child. Are you concerned about the civil rights implications of a vaccine passport? You suggested universities requiring students to be, or faculty members to be vaccinated. Right now, women who are pregnant or trying to get pregnant are not recommended to take the vaccine. Would you be troubled by the discrimination effects of a university that in effect excluded women who were pregnant or trying to get pregnant from attending university? Are you troubled by airlines saying children who haven't been vaccinated are not allowed on the plane and can't travel anywhere? Does that raise concerns that should give us pause?
So first of all, I think the recommendation actually is that pregnant women should be vaccinated. Second, yes, of course, I would be concerned if that were to happen However, I think, look, this is a case where there's going to be lots of opt-outs. It's going to be possible to say, children are excluded. If you have a good reason, you don't need the vaccine. Basically, once we get to herd immunity, these problems are going to fade away. So I don't think, although I would certainly be worried if the things which you described were to happen, I don't think they're going to happen. And the way to prevent them from happening, ironically enough, is look, everyone get vaccinated. Just make it cheap, make it easily available. It needs to be rolled out in all kinds of communities. One of the good things we've been doing lately is getting the vaccines into the pharmacies. The pharmacies have much greater ability to reach low-income minority communities. They're trusted, and so we need to use the pharmacies even more than we have been. And if we get it out widely so that you can just walk into a pharmacy, which is going to be happening. Texas, by the way, has led the way. So Texas should be applauded for leading the way on making it easy for anybody to get a vaccine. Texas has done great in that way. And we should all be following the Texas model, the entire country.
So, Dr. Gounder, I saw you shaking your head when I was asking the question. I would welcome your views. You seem to be disagreeing with the proposition that women who were pregnant or trying to get pregnant should not take the vaccine. So I guess I would ask, what are your views on that, and what are the scientific data that back up those views?
Sure, and it's always great to speak to another.
Quickly, just so we can move on. Thank you.
Sure. It's always great to speak to another Princeton alum, Senator. There is data that demonstrates that, one, if a woman gets COVID during pregnancy, just very similar to the flu, she can have a much more severe case. It is deadly for the mother. It is deadly for the child. She's much more likely to have a preterm delivery. And we've also seen that women can be safely vaccinated during pregnancy, when they're trying to get pregnant, and when they are breastfeeding. And it's the best way to protect her pregnancy and the unborn child.
But are there any data or empirical studies you can point to on that it is safe for pregnant women? I know there are a lot of women who are concerned about that.
Yes, and I'm happy to share some of those after the hearing.
I would ask you to share that with the committee members. I think there would be widespread interest. Thank you very much.
Thank you very much. And now recognize the senator from Minnesota, Senator Klobuchar.
Thank you very much, Chair Beyer, and congratulations to Senator Lee on his work as well on the committee and his new position. And thank you for taking on this really important topic. I look at this in terms of the vaccine a few ways. The first is I have to start at home. I did a number of events on misinformation, starting with at the Mayo Clinic. Made the point that 95% of their doctors got the vaccine. And we still are having issues. I was in a cafe in my neighborhood, and one of the workers there told me that his mother-in-law wouldn't get it because she read on the internet that a microchip would be planted in her if she took the vaccine. So I wondered if Dr. Gounder, you could talk about what's going on and speak to how the misinformation can undermine our efforts and what we should do about it. I have some strong views about the tech companies, but I'm not going to go there today or I'll use up all my time. Okay, thank you.
Yeah, no, sure. I think it's a really important question. There are really two main groups of people who have hesitancy about getting vaccinated. You have people who we would call the movable middle, who are really just straight up concerned about safety and effectiveness. And there has certainly been misinformation about that. And then you have people who really just don't trust government, don't trust public health officials, don't trust the health system. And that's a much more difficult one to overcome. What we have seen with respect to disinformation is that there are a combination of incorrect information that is circulating online. This has been looked at and studied, and there are actually, and I have this in the written testimony, some 12 people who are responsible for the vast majority of that. And they have remained on the social media platforms. They have not been deplatformed. And that would be a highly effective way of dramatically reducing the amount of disinformation, because essentially what's happening is those are the sources that then get amplified.
Oh, I know. Well, it's rare that someone is so practical in their answer. No, I don't mean that to the other witnesses, but so thank you. So maybe we can try to do something about these 12 people. So
yeah, you know, and it's interesting, having spoken to a number of the social media companies, very often you get this answer of, well, it's a really hard problem, we're trying. Look, there's some very practical, easy things they could do here.
Yeah.
So I think that's one. I think it's not just social media, it's also the mainstream media, television, other outlets that are responsible for this. For example, anytime there has been supposedly a side effect related to vaccination, you'll get all the headlines initially reporting that. And then when you have the follow-up data as to what really happened, that doesn't get covered because that's not, you know, as sexy of a story, right? And then finally, the other thing that we are seeing, and this relates to what Dr. Tabarrok was saying earlier about, you know, he would rather see this global vaccination effort be led by the Americans, not the Chinese. I think you're also seeing very intentional efforts by the Russians to smear Western vaccines to make the Sputnik vaccine look better. And unfortunately, that is permeating, you know, what is online and some of what the mainstream media is even picking up now.
Exactly. Okay. Well, thank you. That was a very thorough answer. Dr. Archibald, throughout the pandemic, women, especially moms, have been disproportionately affected by job losses. And I came up with this Marshall Plan for moms to combine a lot of the things that we've learned during the pandemic about childcare and schools and the help that they need. And it's interesting because the last downturn disproportionately affected men. And construction jobs and the like. And this has sent tons of women out of the job market because of the kind of jobs that they lost, but also because they were home with their kids. And now a number of them are starting to come back, but there isn't childcare. Your research has shown that epidemics can contribute significantly to worsening in gender inequality. Could you talk about the policies that would work to address it?
Yeah, no, thank you, Senator Klobuchar. And just as I mentioned to Senator Warnock, this is something where you need any policy, be it from cash grants, stimulus, subsidies to households, to think about the composition of households, to say, look, if there are more women in the households, maybe you want to direct more of these subsidies for childcare towards those households, right? So really having policies that are very gender conscious in how they are implemented is something that has worked in other contexts to try and close these gender gaps that happen after these pandemics. So you know, I mentioned again, subsidies to households, thinking about how do we get women back into the labor market, right? So after the kind of in the post-pandemic economy. So this might involve like work retraining programs and investing in outreach and work retraining that is focused on women. And so that's something that, you know, again, has worked in other contexts, and I think it will be very important to do here.
All right. Thank you. Thank you to all of you.
Thank you, Senator, very much. I recognize the senior House Republican on the Joint Economic Committee, Congressman Schweiker.
Thank you, Chairman Beyer. And actually, a couple things. One, and this is more for you, and I'd like to submit this one for the record. It's an Atlantic article in regards to mRNA technology and the fact that we've just leaped almost a decade in our technology for almost the biofoundry that we actually, you and I talked about a couple of years ago of being a healthcare cost disruptor. So I'd like to submit that for the record. I think you have to say yes.
Without objection, it's accepted. Thank you.
And to Dr. Romer, I would love to try to work with you to encourage Chairman Beyer to do a discussion in regards to labor force participation, where we are in the demographic curve. We actually had a conversation in Joint Economic a couple of years ago in regards to everything from barriers to what was happening out there and it was surprising what we learned from some of the testimony of things we thought were barriers weren't, and things we would have never thought of as encouragements to come back into the labor force to get back up to that type of participation. Mr. Chairman, and this is sort of, I'm going to take advantage of having a freaky smart group of witnesses here. We've been looking in our office at some of the healthcare outcomes, some of the populations that had very uncomfortable mortality statistics, who got sickest, these sorts of things. In my part of the country, being from the Phoenix, Scottsdale area, it's Native Americans. I represent a couple tribal communities. One of those tribal communities may have the second highest diabetes, type 2 diabetes to population in the country. And they had some pretty rough numbers in regards to COVID. So as we have this discussion of getting a vaccine rolled out and efficacies in different parts of the country in different populations, I'm wondering if we should actually have a somewhat different conversation as the Joint Economic Committee. Are we ready to maybe discuss a real disruption? And look, Chairman Beyer knows this. A number of my charts, where over the next, I have a fixation on charts, and I'm not going to show all of them, but healthcare turns out to be the primary driver of U.S. sovereign debt over the next 3 decades. I have a factoid over here that for Medicare is the primary driver of U.S. sovereign debt over the next 3 decades. 30% of Medicare spending is going to be diabetes. Would it be one of the most elegant and very difficult things we could promote as a committee to help minority communities, my Native American communities that suffer from diabetes, at the same time being able to make an argument that this is one of the most powerful things we could do for future debt and spending, but also differential healthcare outcomes? Maybe it's time for an Operation Warp Speed / diabetes. And could technologies such as the mRNA or other things, and look, it's tough because one side we have an autoimmune, the other side we have some lifestyle issues. I'd love some input from the panel with what we've experienced this last year on concentrating resources, moving technology. Could we now take on one of the most expensive diseases in our society? And I'd love to start with Professor Romer. Give me your thoughts. Am I being a bit utopian?
Well, thank you. And I think, no, you're not being utopian at all. I think our consistent failure is that we lack imagination and ambition, because when we try and do something audacious, let's go to the moon, let's build an interstate highway system that links the whole country. When we set a big ambition and then go for it, this nation can do it. So I think, no, we should be setting that kind of a target. And in terms of how we get there, I understand Professor Archibald's hesitancy about my suggestion about just kind of involving the states. I think this is a conversation that we should have, though, and think about a mixed system, because if you think about, for example, like Professor Tabarak's point that we're not running tests to see if lower doses could actually work with the current vaccines. You know, if we had a system where we really relied on the states as the laboratories of democracy, we could have some states that take the lead in trying to say, do the fractionated doses, or a state that could be particularly interested in diabetes and say, we're going to make an aggressive push in trying to treat this. I think what we need is something which is kind of parallel to the universities. We've got a wonderful system of universities across the United States, but you need these organizations that really focus on the transition from the academic research into the public policy goal. And, you know, the mechanisms that can do like what we did with you know, the BARDA commitments on mRNA vaccines. But I think more competition, more ambition would be great.
I'm up against the tyranny of the clock, but it is actually something I would be elated to have input from the panel, but even from my fellow members. Maybe it's time we come together, because this one could be bipartisan, and do an Operation Warp Speed diabetes and bring those goods to all of society. So thank you, and thank you, Don, for your patience.
David, I believe 25% of Medicare is just end-stage renal disease right now. Right, yeah. So let me recognize my dear friend, the good congressman from Madison, Wisconsin, Mr. Wilkie.
Thank you very much, Mr. Chairman, and thank you to the witnesses. I'm one of the new Dems on the committee, so very glad to be with everyone today. Also a 33-year owner of a very small business, under 20 employees. I guess these days people call them micro businesses. I personally hate that term, but a very small business. And it seems like, when we had the 2008 economic crisis, there was a little more, from memory, general malaise. This time there's real almost winners and losers, right? There's some deep industry hits, restaurants and bars, travel industry, meeting industry. And I have a few questions related to that. I'd like to get to a few subjects if I can, so I'll try to be quick for answers. Dr. Romer, you talked about get more testing out there. That's one of the solutions. Let me ask this, because I've had a lot of talks with my state about this. Should we also keep up or intensify contact tracing as part of that answer as well? Oop, you're on mute. I'm sorry.
This is a very good question. And I should say that reasonable people will disagree on this one. I think in general, people think that when you've got a low level of prevalence, then contact tracing is a very good way to try and respond and keep it low. The problem is that once the prevalence gets too high, the tracing system is just overwhelmed. Right. So we need to have a system that works like the kind of screening testing when you get to high prevalence, but also emphasize contact tracing at low levels. The other thing, just to be completely honest here, public attitudes are changing. And I wish they weren't changing, but they are. People are a lot less willing to answer the phone. If they answer the phone, a lot less willing to answer a specific question. Like the yield rate, where you've got you got somebody who's a known positive, and then you try and trace back and find contacts. The yield rates are very low right now. So I wish it weren't so, but it may be that we have to accept that this is the new world we're dealing with, and then try and find some other mechanisms where we can try and address this. And if I can make a tip of the hat to Senator Klobuchar, I think part of why people are so suspicious and so mistrusting is they've had their trust abused repeatedly by these big tech firms. And so unfortunately, it's the government which is now being distrusted because of repeated abuses of trust in the private sector. So I wish we could do something about that.
Thank you. Just to make sure I get my two more questions, I'm going to throw them both out there. And if whoever wants to take them, because you specifically mentioned testing, I wanted to follow up on contact tracing. The second one is, it was mentioned that, if you get one shot, you might just get the sniffles, but two shots, you won't die after one shot, but, otherwise you might just get the sniffles. The question on long haulers, or now, what do you call it, post-acute, whatever the new term we're using. Do we know anything about people who, you still get it now after you've been vaccinated? Does it still have the same potential effect around long haulers? That's the first question. And then the second question is, what is the realistic expectations around summer? So, I happen to, in my small business, we work very closely with the meeting industry, and it's been devastated. People are completely out of work because you can't have, the virtual meeting in the normal way and with the jobs that are there. Someone's looking at a convention of 1,500 people they always have every late August. Is that realistic, or any number like that realistic? What are we honestly looking at, assuming that people keep getting vaccinated and we're keeping on the rates we're around? So sniffles, long-term, long hauler issues, realistic expectations around things like meetings and conventions.
Yeah, I can jump in on some of that. So with respect to sniffles versus severe disease, what you see is you have higher neutralizing antibody levels after a first dose of vaccine versus a second dose of vaccine. So that is going to correlate to some degree with disease severity. But it also, again, it's important to understand that you may have breakthrough infections, especially with the variants after just one dose. With respect to long haulers, the COVID vaccines may actually function as therapeutic for those groups. There are a couple different hypotheses as to why long haulers have the symptoms they do, but essentially by giving them a dose of vaccine, you're priming their immune system to respond to, perhaps there's a latent ongoing low-level virus infection, maybe you have remnants of the virus, but it's causing your immune system to respond to that. And a lot of people are reporting improvement in symptoms. So this is something that's being actively studied right now. If we are able to maintain the same pace of vaccination, we will be in a much better place by the end of the summer. We could be reaching, at least among the adults, the 80% plus range. Of course, you still don't have kids vaccinated, but it really will depend on what happens, whether we can keep up that same pace.
Yeah, if I can just weigh in, I think we got to admit that there's some real uncertainty about what happens this summer. If I were responsible for organizing a meeting, I would set it for September or October. If it were July, I would cancel it. August, you're just a little bit on the edge. And it could be things turn out fine, but there's just a lot of uncertainty about how this will play out. And as I said about Dr. Gunder's point before, it takes about a month after somebody gets their vaccinations to be fully immune. So it's wonderful that we're going to have essentially everybody vaccinated by August. But, we're still going to be in this kind of vulnerable period until we really get into the fall.
Great. Thank you, Mr. Chairman.
Thank you, Mr. Poquet, very much. Now I'd like to welcome another of my Ways and Means members to the Joint Economic Committee, the gentleman from Texas, Mr. Arrington. Floor is yours.
Chairman Beyer, good to be with you, and great to join the Joint Economic Committee and this great group of thinkers and patriots. And as we formulate together the advice and counsel economic policies to get our country back to the pre-COVID prosperity, I'm looking forward to working with you, sir, and my other colleagues in both chambers. Also recognizing Ranking Member Lee for his leadership. I represent a big swath of rural America in West Texas. And we have our unique challenges, and we have some unique benefits to being rural. But I'm very proud of what our state has done, Texas, to balance the various factors that are important, like the spread of COVID, obviously, but also the long-term effects of being isolated and kids being not in school in that very important support system. And whether it's substance abuse or deferred screenings and treatments, there are some major consequences to not getting back and reopening our country, going to work, and obviously with children in school. So no doubt having vaccines widely distributed and the effectiveness and the development of new therapeutics are absolutely key to that. But I've got a question first for Dr. Gunner about the big drop you said in demand in terms of taking the vaccines. And explain to me the reasons for the drop in demand with respect to the hesitancy factor. What are some of the reasons within the different demographics? Women, men, rural, urban, older, younger. I'd like to understand that whole dynamic of hesitancy as it cuts across the different demographics.
So if you look at the demographics and how that correlates with the type of vaccine hesitancy, what we see among communities of color and among younger Americans, it's much more questions of access, of not being able to navigate the system, of getting to a vaccination site. Maybe they're not able to take time off work because they're an hourly wage worker. There are some historic reasons for lack of trust. I mean, everyone always points to the Tuskegee study, but that it's actually a drop in the bucket. There's a whole history of this, even ongoing up until the present day. And I think this is where colleagues of mine like Rhea Boyd, Uche Blackstock, a lot of Black doctors have really done a tremendous job of reaching out to the community. And we've seen the impact already in terms of increased trust, increased confidence in the vaccines. That has not been done with younger people yet. But I think those two groups are a bit easier to get to because in general, their concerns tend to be pretty practical in terms of access, the costs and so on. Then you also have other groups, which includes more rural Americans, more conservative Americans, who just don't like to be told by the government what to do. They don't trust the health system or public health officials or the government. And so
talking to my constituents.
Excuse me?
You must have been talking to my constituents. I'm kidding.
Well, and it's funny, I actually spoke to somebody from Vidaia, Texas, which is between College Station and Houston, a different rural area, but also rural in Texas. And, you know, some of this is also cultural. People want the freedom to do what everybody else like them is doing. And so if it's not what people in their community are doing, they're just going to be resistant. They're not always going to be able to explain exactly why. But we really need to be reaching out through the people who are credible in those communities, who they trust. And very often that is local healthcare providers, their primary care provider, who can really get through here.
Thank you very much. And with my remaining seconds here, Dr. Tabarick, I know a lot of employers that want to respect the personal freedom to choose whether to take the vaccine or not, notwithstanding the fact that we need to be better at communicating the benefits of that to that person, their family, and the community. But I think there'll be some legal liability issues and concerns that if an employer doesn't mandate that with their employees, there may be major lawsuits to bear. Talk about legal liability protections as an important factor in all this, and I yield back.
I think that's an interesting question. I prefer to leave that to a lawyer to answer the details of that. If I could, I just want to say one thing about vaccine hesitancy. One, some of it actually is people who already had COVID, and that's less of a concern. Some people, they don't want to be the first person to get it, but they're okay being the second person to get it. So I think some of it is going away over time. And let me just say one thing about vaccines. I don't like to be told what to, by the government what to do either, but I love vaccines. I love vaccines. To me, it's like a superpower. Right? Because a vaccine gives you the superpower of immunity. And if we could get the superpower of being immune to bullets, who wouldn't want to be immune to bullets? But viruses have killed a lot more people this year than have bullets. So I am very, very happy to have the immunity to viruses. That's a great superpower to have. Everybody should have it.
Thank you very much. Thank you, Chairman.
Thank you very much, Mr. Aronson. I recognize the chairman of the Congressional Black Caucus, dear friend from Ohio, Congresswoman Beatty.
Thank you so much to Chairman Byers for this very academic, educational, and healthy dialogue. Let me say to all of our panelists, thank you for your remarks. I've had a time to go through your presentations and want to thank you for that. Let me just say to you, Dr. Gunner, being the physician and medical person, I've been telling people you listen to our medical professionals and you listen to our scientists. A lot of good information here. Thank you for telling us to meet people where they are. To Dr. Archibald, let me just say thank you for looking at the total picture. Now, obviously, as the chairman said, I am the chair of the Congressional Black Caucus. I represent the largest number of people in Congress in a caucus. It's our 50th anniversary. And when we look at the disparities, which you outlined so eloquently, and I would suggest that everybody on this panel read her presentation because it's real. It talks about the real issues that many times we skate around in hearings like this. Black people are dying disproportionately. There is systemic racism in this country that we have underinsured or not insured. I'm so glad that diabetes came up, my colleague. He is so right. Again, Black Americans and Black men have the highest mortality rate in dying from diabetes. So with that, there's so many disparities. So when I look at the question to anyone on the panel can jump in with this. Do you believe that our economy can get back to normal or at least to pre-pandemic levels without getting to herd immunity? And the second part, if we can't get to herd immunity because of vaccine, and I'm going to add some stuff, not only hesitancy, but the unequal distribution of it, the lack of the vaccine in communities, what kind of effect will that have on our economy? And to be fair, I asked the same question to the Federal Reserve Chair. Anyone, or you want me to call you by name, Mr. Tamara?
Well, let me respond. I think we absolutely have to get to the point where this pandemic is not a cloud that's hanging over the economy if we want the economy to recover. I think we should remember that, that incentives matter, costs matter. A lot of the costs for getting vaccinated is the time to go find a place and to get there and get vaccinated. So I think we should be investing aggressively in things like this suggestion to use the dollar stores as an outlet in parallel with the pharmacies, where it's easier for people to get to one and get vaccinated. I think accessibility should be a huge focus. We should make it as easy as possible for everybody to get vaccinated. And even if people are a little bit hesitant, if you make it a little bit easier, you may be able to get them to go along. So we just need to push as hard as we can on that.
Thank you. And I like the analogy of putting it, I'm going to say, in community centers. Dollar store may work, but in health centers, churches, schools, post offices, etc. To the issue about state government, if we had somebody used the word democracy. Well, if we had fairness in our democracy at the state level, maybe I would support that fully. But right now, when we look at many of the states across this United States, there was a lot of unfairness with what some of our governors said about things that we know was fair, whether it was the election, whether it was Medicaid expansion. Until we do more work there, I think that is very dangerous, or could be dangerous. Last question in my time I have, and maybe Dr. Archibald or Dr. Gunder, you can answer this. There have already been reports that some states around the country are not able to fill the appointment slots for the vaccine. Some reports are projecting that the supply will outstrip the demand nationwide as early as the end of the month. What steps should we be taking in the federal government or even the state to target populations with lower vaccine rates?
Go ahead.
I got about 25 seconds, hurry.
I will just say very briefly, thank you very much, Congresswoman Beatty. One of the things that we mentioned before was saying that given the disparities by race in vaccination rates, it was very, very important to direct vaccines towards local clinics within Black communities, within Hispanic communities, within communities of color. This is where I know we talked about the federalism, but this is where I think a coordinated effort from the federal government with the states would be very, very efficient. But I'm going to stop there and allow Dr. Gunder to chime in.
Yeah, I think we're out of time, but I think this is what the retail pharmacies, the FEMA vaccination sites, the community health center strategy is really all about, trying to focus the vaccination resources access in communities of color, in the CDC, highest social vulnerability index zip codes, to try to really bring vaccines to where people are.
Thank you. And Mr. Chairman, if I could have 10 seconds to say the Congressional Black Caucus. Oh, may I have 10 seconds, please? I'm sorry.
Yes, please. Please proceed.
The Congressional Black Caucus is announced yesterday at the White House with the President of the United States that we are going to have a Congressional Black Caucus vaccination week. Just in parallel after and day, like voting day, early vote, souls to the polls, because we're indoctrinated that that's something our leaders tell us to do and that we're going to do. And the last thing is, you don't have to answer, but could someone send me more on this oral vaccination that I heard you talking about at the beginning? And if that's an option, if we're going to, nobody's talking about that in the Congress or in our communities, that's an option. All we're hearing is either Pfizer or Moderna, and that's by injection. So that would be very helpful if that's real and out there. Thank you, Mr. Chairman, so much for an incredible hearing. Incredible.
And Ms. Beatty, we'll ask the Joint Economic Committee staff to run down the recent research on both oral and nasal vaccine.
Thank you.
Thank you. Now recognize the policy leader of the New Down Coalition and much else, Mr. Peters from Southern California.
Thank you, Mr. Chairman. Dr. Romer, your past statements, I remember you talking about the need for widespread testing availability.
Just leave it up.
So that people can stay at home and isolate if they test possible. In fact, I don't even remember what your academic research is. I just know you're the rapid testing guy, and you've been known for that. And I think that in the context of a lack of trust, that empowering people to be their own actors and their own diagnosers and their own treaters, if you will, makes a lot of sense, could be a game changer. But what about the capabilities? I think only 2 home tests have been approved by the FDA. You've described some of the benefits of this, but does the FDA have the testing capabilities in the pipeline for approval to do the carpet bombing that you've described?
This is an area where I think one has to take a nuanced approach. I think, for example, it's important for the FDA to be extremely rigorous and demanding and cautious about vaccine safety. So I think, jumping in actively when the first signs of the J&J problems emerged was the right thing to do. This is very important for kind of sustaining this broad social consensus that vaccines are something that we should all take. But on the other extreme, on the process for approving tests, I think the FDA has been a huge bottleneck, and a really just a tragic bottleneck, very concerned about small issues and not attentive to the huge benefits that could come from just trusting people at home with a little bit more information about their own healthcare condition. Now, there's reasons why the FDA kind of historically came to the position where it is, but they need to be quicker to update and say things have changed and we got to be able to respond more quickly. So to be honest, I think, no, the FDA is still going to get in the way. If we tried to carpet bomb Michigan with these kind of home rapid tests, I think the governor of Michigan ought to just say, I don't care what the FDA says you can do with these tests. Right. I'm going to say we're going to send them to people's homes and they can use them, and then the FDA can come after me if they don't like it.
Just one thing I would add.
Oh, sorry.
Yeah, sorry. Just one thing I would add to Dr. Romer's comment on the mass testing. I think that works if people are able to stay home. I mean, this is something I see all the time as someone who discharges patients from the hospital who had COVID, and we ask them to isolate afterwards until they're fully out of the infectious window, and they're not able to because they have to go back to work. And so for this to work, you need to make it such that people can stay home.
But that's two problems. Right. That's two problems though, isn't it? I mean, the first problem is still empowering patients to know what they're up to, and then giving them the autonomy to act based on that information. And I think, the notion that we should be in the way of this really flies in the face of the trend toward a patient empowerment and responsibility for your own health, which I think is inevitable. It's coming. And we have to take advantage.
If I could just say, if you want to think about how this system can work, you could have people doing these at-home tests that they test positive. They might then have the option to go and get an official, PCR confirmation. Then if they get a confirmation, the government could pay them their lost wages to stay home. Not that many people are positive. It wouldn't be that expensive. We could do this.
Right, it could be tailored. Let me ask a question about something else, about confidence in the vaccine. There's a decision made to shelve the J&J vaccine because of very, very few, but admittedly serious consequences. I was in local government. I know people don't analyze risk the way that you do. I think that's the end of the J&J vaccine in terms of acceptance. I'll be interested in hearing Dr. Gounder and maybe Dr. Romer. What's your reaction to that? I mean, how do we inspire confidence in the face of what I think may be an overreaction?
Well, I think it's important that we maintain confidence in our vaccines more generally. The Pfizer and Moderna vaccines are highly effective, highly safe. The fact is, with the issues that
J&J, right? I mean, J&J is also highly effective.
Well, it's highly effective, but we're still evaluating, as you said, very rare but serious complications. The fact is, our vaccination supply, we have enough vaccine to vaccinate our American adults, even without the J&J, number one. Number two, there have been manufacturing issues, as you're probably aware, at the Emergent Biosolutions manufacturing plant in Baltimore. And so we were anticipating already that supply really slowing down over the next couple of months. So I don't think this is going to have a huge impact, frankly, for most of our vaccination efforts. It's really going to be most important for certain hard to reach communities in this country and really for the global vaccine supply.
All right. Well, thank you, Mr. Chairman. My time has expired. I'll yield back.
Thank you. Thank you, Mr. Peters, for making the interesting psychological argument about what happens when you challenge the efficacy of something, rebuilding that trust. And we wrap up with Congressman David Trone from Maryland, who is one of the most successful business people I've ever known. David?
Very generous. Thank you, Mr. Chairman. Dr. Gallagher, as we continue to recover from COVID, one issue that many families mind is returning to school with their kids. Having all adults eligible by April 19th, great first step, but the reality is many children will not yet receive a vaccine. Recently, I hosted a Q&A live with Dr. Fauci, and my chat box was blown out by constituents asking, when will a vaccine be safe for my kids? And when will it be safe for my kids to return to school? So how difficult is it going to be to reach herd immunity until we get the vaccine approved for children of all ages?
Well, Pfizer has submitted their vaccine to the FDA for emergency use authorization for kids 12 and up. And I anticipate that that will come through pretty quickly here. And so that actually will help us, especially if we start to see the demand for vaccines among adults slow down, then you might actually see adolescents picking up, taking some of those empty vaccination slots in the coming months. And I don't think that would be a bad thing if we can expand vaccine coverage that way. With respect to schools, I think we've learned a lot in the past year. It's really been a crash course in this virus. And in the beginning, we thought this virus was largely transmitted through droplets and through contact, skin to skin contact or contact with contaminated surfaces. And what we've learned over the past year is that aerosol, airborne spread, is really probably the more significant driver. And so what that means is that your mitigation measures, your infection control measures in the school may be different. If you're talking about surface contact, you're doing the cleaning of surfaces, and the hand washing. If you're talking about droplets, it's a combination of wearing masks and the 6 feet apart. But if it's aerosol, airborne, then it's masks and ventilation that become the most critical things here. And you don't want to have a high density of people in that room, but they can be closer distances together as long as you don't have high density. So what we've learned is you can reopen schools safely as long as you have the masking, the ventilation, reasonable classroom density, testing, as Dr. Romer would advocate for. And the other thing that we've learned is when you see transmission in schools, it's largely adult to adult. It's not children to adult. And when children transmit, it's usually in the setting of play dates or sports team activities outside of the classroom, not in the classroom. So based on what we've learned, we really can reopen schools safely as long as you can continue with those mitigation measures, the masks, the ventilation, ideally testing, even if you don't have mass vaccination of the students yet.
Sorry, if I could just weigh in on this too. Of course, I approve testing, but one of the things I wish we had committed to in this new infrastructure bill was a massive upgrade in the quality of the ventilation and the air quality in schools. This could help with the current COVID pandemic, but with future viruses and even other health issues related to particulates. So if we made the right investments, we could have much cleaner air, and there a lot of good would come of that, much cleaner air in schools.
No, I completely agree with you on that 100%. I sit on a bunch of school boards and couldn't agree more. Dr. Gallagher, again, quickly, with the J&J problem coming up, the AstraZeneca challenges on their vaccine also, I mean, we've got to figure out how to get COVID out, vaccine out to the entire globe. And, with these poorest countries, getting them equal access to a safe and effective vaccine. Could you speak a little bit about what efforts we're trying to help these other countries on the poor side acquire a vaccine, and the issues now with AZ and J&J that this is complicating it?
Yeah, so what's great about both of those vaccines is they're cheap. They don't have the same strict cold storage requirements that you have with Pfizer and Moderna. And so we were really counting on AstraZeneca and Johnson & Johnson for our global vaccine supply. And the Merck Johnson & Johnson collaboration, Merck assisting Johnson & Johnson, which is really an astounding feat that is happening. but the idea that they would help scale up supply was really intended for the world. And the other vaccines that are being used, say the Sputnik vaccine, the CanSino vaccine out of China, these are also adenovirus vector vaccines that may have some of the same complications. We don't yet know. But I think what I'm most concerned about with respect to how this all pans out is what will this mean for vaccinating the world?
If I could just weigh in as the former World Bank, chief economist, the World Bank is saying somebody else needs to go donate a bunch of money to help vaccinate the world. We got to remember that was the job of the World Bank, is to help poor countries. They're spending a lot of money, including their concessionary aid, on things with a very low bang per buck. And as Dr. Tabarrok has shown, the bang per buck on these vaccines is extraordinarily high. So we should be putting a lot more pressure on the bank to not just engage in business as usual, but go out and pay for the vaccinations that people need in the developing world.
Can I just add someone to, I have expertise in African countries. I would highly encourage Gavi is the Vaccine Alliance, there definitely needs to be more funds, accorded to them, because they're doing really, really good work in African countries. Just, to highlight that there.
And
let me
with
just add
that,
one thing, which is for the rest of the world. I think it's important to underline. It is much important to get. It's more important to get vaccinated now. Use the AstraZeneca. Use the Johnson & Johnson when the pause is over. It is much, much more important to get a early vaccination. Don't wait for Moderna and Pfizer. It's going to take too long. Okay, take the vaccine, whatever you can get now. The Russian vaccine is actually pretty good. Use the vaccines that you can get access to and start your vaccination early. That is the message to take to the rest of the world. The US is very fortunate. We have Moderna and Pfizer. The rest of the world, you vaccinate early and vaccinate often. That is the route to health and to wealth.
and the message that I have to give to you guys is that the votes are going to close in 3 minutes. And since I'm carrying proxies for a number of other people, I have to go. But I want to thank you very, very much. This is a fascinating hearing. You managed to keep senators and congressmen here for 2.5 hours, which is a wonderful thing. I'm very grateful. This will be, record will be open for 3 days. This is recorded. I'm sure tens of thousands of people across the country will watch what you offered this afternoon. So thank you very much. We hope to work with you again in the years to come. With that, the hearing is concluded. Thank you.